Good afternoon and welcome to Grand Rounds. It's always a challenging thing to present to this group of people because we have such a diverse audience of students and house staff and then faculty with years of experience to talk about different things. And so I wanted to put a talk together that I thought was something that we use or we see on a regular basis. Bob Walter talked about COPD, which is what I had planned on talking about earlier. He beat me to it. So I thought, well, what's another topic that we can talk about that I think is very apropos, particularly to the house staff, but also to our practicing attendings and everything as well. And it's respiratory failure. It's something that we see about, a lot about in dealing with patients, particularly in the hospital. And in particularly, I wanted to talk about non-invasive ventilation because it's something that has developed really from the time that I started as a resident and as a fellow to becoming something that we use, fairly routinely. And so kind of wanted to look at how we got to where we are with using non-invasive ventilation and how it's helpful for us in management of our patients with respiratory failure. Now my title is some of y'all, at least some of the older faculty that were here when I was a resident and a student here know that I have participated some in community theater, and so this is a little bit of a homage to Shakespeare, to be or not to be, to invade or not to invade, and that's where the masks also show, or the drama mask. But really, I got to looking at that and I thought, well, that's really something that we see also. Our house staff are very happy when they hear somebody's got respiratory failure. Let's go intubate them. I'm ready. The sad face is maybe our patients seeing our house staff coming towards them with a tube coming to put it down their throat and everything. But anyway, that's kind of where we are with this title today. I don't have any conflicts of interest. I have been accused that my middle initial stands for CPAP, but it does not stand for CPAP. But I do like to use non-invasive ventilation and have used it frequently in my training and then as I got out into practice as well. So the objectives that I want to try to cover today, and it's going to be kind of mixed up a little bit, is to identify respiratory failure and discuss the causes of respiratory failure. This will be pretty basic. It gets back to the things that we've learned as first and second year med students, but it's something that we really need to be aware of in our practice and our approaches in dealing with respiratory failure. So we discuss kind of the approaches to dealing with respiratory failure. How do we assess it? Discuss the application of types of non-invasive ventilatory support, and then to maybe discuss a little bit the pros and cons of invasive versus non-invasive ventilation. Hopefully you'll get all of that out from the talk today. So the best way to start off with, I think, is to use a case that maybe helps to describe or gets us to understanding where we're going with things. And so look at a typical patient that we see at LSU, a 68-year-old woman who comes in, has a history of some obesity. She has hypertension, diabetes, and chronic tobacco use. Somebody that we see in our patient practice every day. Comes into the ER with some shortness of breath over several days. Notice that she's really been feeling short of breath for several weeks, but over the last 3 or 4 days has gotten particularly worse. Has had a cough productive of some light yellow sputum. Normally smokes about a pack and a half of cigarettes a day, but over the last 3 days has really only been able to smoke 2 or 3 cigarettes. So she's got some problems coming in. Feels much worse after she smokes. How many of y'all have heard that story, as you're dealing with our patients coming in? She's got a diminished appetite because she's short of breath. She denies any chest pain, no fever or chills. Has been using an albuterol inhaler that she's gotten from a friend. She has never been on any therapy, and some friend just happens to give her their albuterol inhaler. She noticed some initial improvement, but really over the last 2 or 3 days hasn't gotten any better. You examine her. Notice that she's moderately obese. She's using her accessory muscles to breathe, and she's sitting up fairly straight as well. She's able to speak, but she's only in short, complete sentences. Her respiratory rate's somewhat tachypnic, 24 to 28 times a minute. Her heart rate's tachycardic. Her blood pressure is slightly elevated. She's afebrile. She appears to be overweight at 194 pounds. She's got diffuse wheezing with a prolonged expiratory phase and irregular rhythm and some trace pretibial edema. So it's a pretty common patient that we see. And in evaluating her, we started her on some, in the ER, they started on some oxygen. They put her on breathing treatments with albuterol and ipratropium by nebulizer, giving them back-to-back to try to see if they can get her to improve with her breathing. They get a blood gas on her, and we see that her blood gas shows that she's got a PO2 of 58, PCO2 is 56, and a pH is 7.33. So it's a little bit abnormal. You get a venous blood, and it shows a bicarb level of 30, and a BNP slightly elevated at 515. You get a chest X-ray, and it's pretty unremarkable. May have some hyperexpansion, but otherwise no real clear infiltrates. Maybe a little something over here in the lingula, but certainly nothing that just jumps out and says, I've got a terrible pneumonia. So the question is, what should the next step in treatment be? And so what I had intended to for this talk is to have the audience participation to be able to pick your choices of what our treatment is, but I didn't get that into Kathy in time. So we'll do it the old-fashioned way. I'll have people raise their hands to see what we think. So A, continue with current therapy. B, intubate the patient and institute mechanical ventilation. C, start the patient on Heliox. That's something that you may see us do from time to time. D, initiate non-invasive ventilation using a face mask and a ventilator. E, run away. Or F, consult your friendly pulmonary critical care team. And so there are several good choices that you could consider in dealing with this. And so you really have to ask yourself, what is the problem? And what we're dealing with is she has respiratory failure. If you look at her blood gas, she's hypoxic. She has some hypercapnia. She has maybe a little bit of acidosis, respiratory acidosis on her blood gas, so it looks like it's somewhat acute. And so what we need to do is, how do we deal with respiratory failure? What are the approaches that we take? We need to determine the cause of what is their problem. Why did they get to this way? We need to initiate treatment, and then we assess our response to treatment as well. And some of these things are ongoing all at the same time. Just this person came in the ER. She got started on respiratory treatments. We got blood gases to see where she is, and then we're looking to see how she does. And so what do we do? What is respiratory failure? Well, so there's several things to look at with respiratory failure, and one of the biggest things that we have to deal with is it can be a failure to oxygenate. Okay, we have a low arterial PO2 on our blood gases. And the causes of those are basic. We go back to our first or second year medical school, and we think about the causes of hypoxia, and they're basically 5. Either hypoventilation, the person is not breathing. You may have VQ mismatching, such as we see in COPD, asthma, pulmonary emboli, and that's generally what is going to be our most common causes of hypoxia. We have right to left shunting. We may have congenital heart disease. They may have right-sided heart failure with a patent foraminal valley. They could have AVMs in the lungs as well. They could have diffusion abnormalities such as interstitial lung disease, heart failure, or they could have low inspired oxygen levels such as they're at the top of Pikes Peak, or we always hear Mount Everest, but I like Pikes Peak because it's American. So anyway, so those are the things that you have to ask yourself. What is the cause of their hypoxia? Why are they having hypoxia? And so then you direct your therapy towards that. The other thing that we may see with a respiratory failure is a failure to ventilate. We see that with hypoventilation. So the PCO2 may be high. So what are things that cause hypoventilation? Well, they may be oversedated. Say they're on sedation. They're on narcotic pain medications. They take medications at nighttime, or they get a combination of these medications. They may have an increased work of breathing. Say that somebody's coming in with a COPD exacerbation and they're breathing really fast and they're starting to tire out so that they're struggling to breathe, and so they may be starting to have a higher CO2. They may have neuromuscular disorders, say myasthenia gravis or Guillain-Barré, or they may have muscular dystrophy that causes them to not be able to ventilate. They don't have the pump to be able to get rid of carbon dioxide like they need to. Or they may have skeletal abnormalities like scoliosis or kyphosis. We can see some patients that have pretty severe skeletal abnormalities that affect the way that the structure of the chest allows for appropriate ventilation. And so those are things that you have to assess. What are the things that cause respiratory failure? Those are just some examples. These may be acute, may be chronic. Okay, so we can have some people that have scoliosis that's long-standing that they've been dealing with chronic respiratory failure, or they have chronic CO2 retention from severe COPD that they've been dealing with all their life. Or you may have acute on chronic problems, just like our patient, I think, coming into the ER that we've been talking about. So how do we assess respiratory failure? Well, blood gases are one of the big things that we use. We look at their PO2 and their PCO2. Normal PO2 is 80 to 90. On room air, normal PCO2 we see is a range of 35 to 45. Again, those are pretty basic. Then, I know y'all love equations. We have the alveolar air equation. We can calculate what they should be seeing in their alveolus. Okay, on room air, if you look at the alveolar air equation, alveolar PO2 should equal the fractional inspired oxygen. So in room air, that's 21%, which you take barometric pressure at sea level, 760 minus 47, which is for the pressure taken out for water vapor pressure. So that'd be 713 would be that number. And then you take the PCO2 and divide that by the respiratory quotient, which is a ratio of CO2 production to oxygen consumption. And that normally is about 0.8 in a normal person. And so if we use values at sea level and at room air and a PCO2 of 40, we'd have a normal alveolar PO2 of about 100. So that would be something that you would expect. And then we can calculate the AA gradient based on what their blood gas shows us, what their AO2, their little AO2 is. Take the difference from their alveolar O2 and see if they have an oxygenation problem. Okay. Normally that gradient is about 10 in a healthy young person. As we get older, we have some disease, and so it can be less than 20 as we get older. So that's one of the things. What about pulse oximetry? We see that a lot as we assess patients, and pulse oximetry, I think, is a very important tool that we've developed and used over the course of time. It's helpful to decrease the need for blood gases. Your patients generally don't like to be stuck, particularly for blood gases. They're uncomfortable. Pulse oximetry is convenient and it's much more comfortable. Frequently, it's called the fifth vital sign, so it's readily available. And our goal in treatment, obviously, is we try to keep them above 90%. Now, why do we want 90%? Well, if we remember the oxygen dissociation curve, 90% is up at the top right here. So we have good oxygen in our blood. We're able to get good oxygen exchange in the tissues, and when oxygen levels are lower, it falls down. Oxygen carrying capacity is low, and so we're not delivering as much oxygen as well. But 90% is where our goal is for therapy. Again, somebody who has a PO2 of 80 to 90 is going to be in the range of 98, 99%. So if somebody walks into your office, you check a pulse ox, and there's O2 sats 94%, they're low. You say, say 95%, you're looking at a PO2 of around 70 there. So you know that person is not normal for the most part, or you would expect that that's probably not a normal PO2 for most people. So they have some kind of problem. Again, this may be a chronic problem or acute problem, so you have to remember, put it in the context of where you're treating this patient in dealing with this. So oxygen therapy is one of the things that we typically use first in dealing with respiratory failure. You call your EMS, they come to your house, they don't slap a ventilator onto you, you're breathing, they put some oxygen on you. It's our initial mode of treatment, and it helps to restore adequate oxygenation and help with the treatment of the hypoxia, because that's one of our biggest problems with respiratory failure, is making sure that we have adequate oxygen for our tissues. It helps provide support to the patient while we're going and assessing the underlying cause, and while we're treating it. It also requires that you have to have a cooperative patient. We see a patient who's confused and they're thrashing around. It may be difficult for them to keep their oxygen on, so you have to remember that. And you can also have pitfalls with too much oxygen therapy. So we have several different types of devices that we can deliver oxygen with. These are pretty basic. We have nasal cannula. I'm sure y'all recognize this. It's easy to use. In a basic oxygen nasal cannula can deliver up to 6 liters of oxygen flow per minute. Or we have the new higher flow tubing that you see that has the green tubing that can give up to 10 to 12 liters per minute of oxygen flow. One of the downfalls of this is, particularly with higher flows of oxygen, is it can cause problems with nasal drying and cause nasal bleeding. So you have to be a little bit cautious about using those high flows of oxygen for a longer period of time. This is a non-rebreather face mask, another thing that you may see readily available to help treat people who are short of breath and having breathing problems. Frequently used in emergencies. Allows, again, to give a high concentration of oxygen. It allows a more enriched oxygen environment around the nose and the mouth so that you breathe out. It has a little one-way valve that allows your expired gases to get out and not stay in the same environment. You have oxygen that's flushing that out so you can deliver a higher amount of oxygen. Requires about 10 to 15 liters of oxygen flow. But this also is very dry gas and that kind of thing. And so if you have somebody who's been on this for 2 or 3 days, their mouth may be all dried and then they're having problems, and you go to intubate somebody and they'll have a big cake of a big brick of inspissated secretions in there. So it's one of those things that you may not want to have to use for a long period of time if you can keep from it. Another device that you may see is a Venturi mask. This is kind of a mixture of the two. It allows you to vary the flows of oxygen. You have several different valves that you can provide different concentrations of oxygen to the patient, up to about 50% of oxygen. Allows them to breathe in some and trains room air into there so that you get the humidity from the moisture from air, so it helps to keep some with drying of the secretions. Other things that you may see are an aerosol mask, which gives higher flow oxygen, higher concentrations of oxygen with humidity, and helps to prevent that drying of secretions. So that's kind of there. So let's get back to our patient. So we put the patient in the hospital, put them on oxygen, started them on respiratory therapy with some inhaled bronchodilators. We've given her diuretics because it looks like she may have a little touch of heart failure. BNP was elevated. And the floor nurse calls you to say that the patient seems to be more sluggish. She's not responding quite as easily with her mentation. You get a pulse ox and it's reading 97%, so you're really good there. But you said, well, let's get a blood gas in just to see where we are. So our PO2 is 84, so we got a good PO2. We got a good oxygen level. We're above 60. But our PCO2 is a little bit higher than what it was. We were, I think, 58 or 56 before. Now we're up to 72, and our pH has dropped down to 7.22. So what should our next treatment be? Immediately intubate the patient? Should we turn the oxygen down to keep the oxygen at approximately 90%? Should we initiate non-invasive ventilation? Should we continue with our present course of therapy? Or should we transfer to the ICU for closer monitoring? Again, there's several answers that you could probably look at here and make a good case for all of these. And so I'm kind of go through some of the thinking about what I would do in this case, or where we would go with this. So one of the things that I talked about is the pitfalls of oxygen therapy and hypercapnia. So we know that our normal control of breathing is our PCO2 is what stimulates us to breathe. So when our PCO2 rises, we tend to breathe faster. And so in patients who have chronic respiratory failure, however, this may be altered some so that they accept a little bit higher PCO2 level to stimulate them to breathe, or to accommodate their respiratory or their disease. And so they become a little bit more dependent on their oxygen levels to stimulate them to breathe. And so if their oxygen levels, which normally for them may be around the PCO2 of 60 or so, are treated with oxygen, so you say you put them up to a PO2 of 84, maybe they may not tend to breathe a little bit. At least that's what some of the things that we've been taught. And so that giving supplemental oxygen may cause a rise in our PCO2 and cause a worsening of hypercapnia. So that may be some of what happens, but another thing to think about is the Haldane effect. Okay, this is another physiologic principle to remember, that not only does oxygen bind to hemoglobin, but carbon dioxide also binds to hemoglobin, and there's some competition for this. This allows carbon dioxide to be picked up in the tissues and brought back to the lungs to help to eliminate it in the lungs. But when oxygen binds to hemoglobin, it tends to knock the carbon dioxide levels, or carbon dioxide off, and so that causes your PCO2 then to be elevated in your blood. Also, oxyhemoglobin hemoglobin is a weak buffer as well, and so when oxygen binds with hemoglobin, it allows the acid that it buffers to come off, the protons, to bind with bicarbonate, and then this also promotes the conversion of CO2, again, ultimately causing your PCO2 to rise. So this may actually be some of more of the effect that we see acutely when we give oxygen to somebody for treatment of respiratory failure and they have problems with worsening hypercapnia. The ultimate result is we get worsening hypercapnia, and so causes an increased PCO2, which then can cause somnolence. And so what we can try to do, one of the options that we had in our treatment would be maybe to try to decrease our oxygen levels so that we get their their O2 saturation back around 90%. You come back and you repeat their blood gases a little bit later, and you may see that their PCO2 is actually down and the patient's a little bit more awake, and then you can continue on with your treatment. So that's one of the things that you can do. But the other thing that you can do, and what I really wanted to kind of talk about, was non-invasive ventilation. Non-invasive ventilation, like I say, it's been around for a long time. There's been different types of non-invasive ventilation. This is iron lungs that they used to use back in the 1950s, and I guess 40s and 50s, and I guess some in the 60s, particularly for patients who had polio. This is a negative type breathing apparatus where you put the patient in there. It creates a negative pressure that causes chest expansion, and the patients are able to breathe because they had neuromuscular problems. Obviously, we don't use these a whole lot today. They're bulky. We don't have big rooms that we can put hundreds of these ventilators in the rooms easily. We try to keep our patients more in individual rooms. And so we've gone more to using positive pressure ventilation. This is a typical what you may see of somebody with sleep apnea or that kind of thing, but we can also use this in patients who have respiratory failure. There are different types of non-invasive ventilation. If you look at normal breathing, we normally, when we breathe out, we have a little bit positive pressure in our breathing. Then when we breathe in, we have a negative force to start or to initiate the flow of breathing. We have CPAP, which all that does is it moves this baseline pressure of where we're breathing from 0 up to 10. It allows us still to have that same respiratory pattern of negative pressure in, positive pressure out with breathing. Some people can tolerate that, and that can be helpful. The other alternative that we have, and what you may see that we use frequently, is either BiPAP or pressure support ventilation, bilevel ventilation with pressure support. Those are two kind of modalities, and basically are the same thing. You have somebody breathing at a baseline level of expiratory pressure of, say here would be 10, and then you may have an expiratory or an inspiratory pressure, an IPAP of 22, which would be up to here, or a pressure support of 12. Pressure support is the pressure that is above the baseline level of breathing, and that helps you to generate a tidal volume. And both of these have been shown to be helpful in management of patients with respiratory failure. So, who are patients that we've looked at to use non-invasive ventilation with, and it's been shown to be helpful? Some of the biggest data that we have is in using patients that have COPD, and that's where we kind of first started looking at it back in the 1990s. This is a compilation of several studies that were done in the 1990s looking at patients that were treated with non-invasive ventilation versus standard therapy, which is basically giving them oxygen. And what you could see in all of these studies, although the numbers were somewhat small in many of them, that the numbers in parentheses are the numbers of people that failed the treatment and had to be intubated. And in generally all of them, the patients that were treated with non-invasive ventilation showed fewer failures in treatment compared to standard therapy. So you had more people requiring intubation than they did in the non-invasive ventilation. This number here is actually 92, so I think they just got those numbers transposed. The other thing that several of the studies show, they looked at what the PCO2s were and the PO2s before and after they initiated therapy. So B is at the baseline, and then this is generally used about 1 hour after they started treatment. And you can see in most cases, the PCO2 went down and the PO2 actually went up in these patients. So we've seen that this can be an effective way to treat people with respiratory failure related to COPD. Okay, and it has led to the fairly standard therapy of using this kind of as a good first-line treatment of people who come in and see with respiratory failure with COPD if they can tolerate this. Also, we've looked at it in acute pulmonary edema. Again, there were some meta-analyses in the early 2000s looking at it in use of non-invasive ventilation versus standard therapy. Again, oxygen therapy in acute pulmonary edema, and they looked at studies looking at both mortality and intubation, and you can see that the studies all favored the use of non-invasive ventilation versus standard therapy for for treatment of patients with acute pulmonary edema to reduce the amount of intubation and use of mechanical ventilation in these patients. And also these studies showed that they reduced, when you use non-invasive ventilation, you reduce their ICU length of stay, you reduce their mortality, and so you can improve patient care. So we know that in these two groups of patients that it's used, it can be helpful and useful and is recommended. What are some other conditions that we can use non-invasive ventilation that have been looked at? They've looked at using it in immunosuppressed patients, and it has been shown to reduce the number of intubation rates and decrease the occurrence of sepsis and septic shock in patients who have respiratory failure. You can look at it in patients who do not intubate patients. And this is somewhat controversial because you are using a life support for some of these patients. And so if somebody has an acute process that may be reversed, say you have somebody who's got severe COPD who doesn't want to be intubated, but they're not ready to, they would like to try to do what they can to reverse anything acutely, you might can use it. But if somebody, you're looking at this for a long-term type care, then it's probably not an appropriate thing. So you have to put it in the clinical context of where you're using that. Post-operative patients, we can use non-invasive ventilation in patients who have some respiratory deterioration after surgery. You can see up to 36 hours after surgery. It may help to delay or prevent intubation and may help improve the outcomes in those patients. And also in patients to help wean from ventilation. So say you have somebody who's got bad lung disease, they come in respiratory failure, they get intubated in the emergency room. You may can try to extubate them and use non-invasive ventilation to try to help to facilitate their weaning from ventilation. They may not be able to breathe all on their own just immediately after you extubate them, and so you can use non-invasive ventilation. Those are some ways that we've looked at to try to help use non-invasive ventilation as well. So in the use of non-invasive ventilation, A, should always be considered for the management of respiratory failure. Well, we discussed a little bit of that. B, can it be as effective as invasive ventilation for improving gas exchange? C, is it easy to initiate and less time-consuming than conventional ventilation? D, it should only be used in patients with normal mentation. Or E, it can solve world peace. Okay, well, again, there's several different things that you could look at in these answers. And what you need to look at is when to consider non-invasive ventilation. So you have somebody who's got respiratory failure. We look at their PO2s less than 60, and they've been on oxygen and they're not responding. This would be a good person maybe to consider non-invasive ventilation. Their PCO2 is above 55. Our patient when they came in was 58, so that might have been a good time to go ahead and just start non-invasive ventilation. The pH is between 7.1 and 7.35. They're acidotic, but not severely acidotic. They're less than 7.1. That can generally be suggested that you use non-invasive ventilation there. Somebody who has a severe COPD exacerbation, we've already shown that at least some of the literature suggests that it's very good for use of treatment of patients with COPD. You have patients who have acute pulmonary edema. Again, it has been shown, the literature supports that that's something that you would want to consider using at that end. If patients have severe dyspnea and they're using their accessory muscles, it's something to consider. And that's, I think, where we're using it even more and more these days, although with maybe less literature to support some of that. When to not use non-invasive ventilation. I guess that's kind of a double negative, not non-invasive ventilation. So if somebody's not breathing, you have a respiratory arrest, that's generally not a good time to use non-invasive ventilation. You need to go ahead and intubate that person because they're not going to generate airflow. They're hypoventilating, and that's not a good time to use non-invasive ventilation. You have somebody who's medically unstable. They're hypotensive, they're in shock, they have evidence of cardiac ischemia, or they've got severe arrhythmias. I probably would not use non-invasive ventilation in that setting either. If they're not able to protect their airway, so they're not able to cough, they're not able to clear their secretions, they have an excessive amount of secretions, or they're agitated, they're not able to keep their mask on, that's another time that you're going to look at. They probably are not going to be good candidates for non-invasive ventilation. Also, if they've had some trauma to their face, they had burns or they've just had surgery or something like that to their face, it's probably not a good time to use non-invasive ventilation because you may have problems with fitting of the masks. So what about comparison of non-invasive ventilation to conventional ventilation? Well, this is a study done back in the late 90s that compared actually non-invasive and conventional ventilation, and it did show that you actually can improve their oxygenation about the same as you can with conventional ventilation. It was a randomized control. It was a small trial of only 32 patients, or actually I think 64 patients, where they showed that after an hour of treatment, you actually had similar improvements in oxygenation. And this was defined as their PaO2 to FiO2 ratios. They noticed that when they used non-invasive ventilation in their patients, that they had fewer complications. They had less problems with pneumonia. They had shorter lengths of stay. But again, this was a small study, but it did lead us to consider using non-invasive ventilation when it's appropriate. And I think that's the key, is that you want to use that it's appropriate. What about use of non-invasive ventilation in ARDS? Well, it's something that we can try, but this has actually just come out recently, past month online, in a study called the Lung Safe study, which is an observational study looking at treatment of ARDS in a multi-center study. And they showed that in the treatment of ARDS, they saw that non-invasive ventilation was used about 15% of the time. But it did not seem to show any significant difference in mortality or that kind of thing, comparing non-invasive ventilation to invasive ventilation. But what they did see is, particularly in patients that tend to have more severe disease, and that's with a PaO2 to FiO2 ratio of less than 150, so these are patients that have fairly severe lung disease, that there actually was an increase in mortality if you try to use non-invasive ventilation in those patients. And so it's probably, just looking at this, at least their recommendation would be that you may not want to use non-invasive ventilation. You just go ahead and intubate those patients. They're probably they're sicker and probably have other things going on. They may be more unstable hemodynamically as well, so those are things to consider as well. They noticed that about a third of the patients that were treated with non-invasive ventilation ended up failing and needed intubation anyway. So you need to be careful if you're considering the use of non-invasive ventilation in ARDS patients. You need to pay close attention to them. And so it's not something that you can just use and walk away. The other thing to think about is that non-invasive ventilation is a good modality to use, but it's not simple. You can't just put it on somebody and walk away and expect them to get better, because again, you have to consider, are they going to be able to tolerate it? Are they having problems with secretions or that kind of thing? And so you want to select your patients. You want somebody who's cooperative. You want somebody who's early in respiratory failure, not late in respiratory failure. Somebody who's obtunded, about to stop breathing, is probably not a good person to put on non-invasive ventilation. You want to think about the patient. Does this patient have severe COPD or acute pulmonary edema? Those are the ideal patients to put on non-invasive ventilation, because we know that it works and can work well in those patients. And it's a process that you want to make sure that they have a process that kind of improves quickly, because keeping them on non-invasive ventilation for several days can be pretty uncomfortable for the patient if they've got this mask that's stuck to their face, just like if they've got a tube stuck down your throat. And when you have that ongoing, it's harder for you to do other things for the patient as well, so that they can't eat because they've got a mask over their face and that kind of thing, and it's hard to deliver nutrition. You can't put an NG tube in them, but then you have to break their interface from their non-invasive ventilation. So those are things to consider as you're treating these patients. There's also technical consideration. You want to make sure that they have a face mask that they can use that comfortably and that they can tolerate. You want to use a ventilator that can accommodate an air leak. And most of our newer ventilators can accommodate air leaks. They have actually specially designed ventilators that we use. You've seen them on the floors here that we use strictly for non-invasive ventilation that accommodate for the air leak that you get around the mask. You need to provide continuous oxygenation and hemodynamic monitoring as well, to make sure that they're not declining, because these patients can get worse and may need to be intubated, and you need to have personnel who are familiar with the equipment. So you want to have respiratory staff and nursing staff who are familiar with what you're doing. So And then you want to assess treatment. You want to assess it early. So if you look at the studies that were done, they looked at how are they doing in 30 minutes, an hour after they've been on treatment. And that helps you to decide, is this something that the patient is going to be able to tolerate for an ongoing period of time, or are they declining on this therapy and you need to go ahead and just bite the bullet and intubate somebody. You need to assess them frequently and you need to watch them closely. So putting them in an ICU or a closer monitoring situation like step-down unit is generally a better idea initially when you start somebody on this therapy. These are some pictures of some of the types of masks that you may see on non-invasive ventilation, and there's basically 4 types of masks. The nasal mask, this is what we typically see on patients who are on CPAP. You can try these on patients with non-invasive ventilation. One of the biggest, and this is what we used a lot early on because CPAP with sleep apnea was something that we used frequently. The problem with this is a lot of times you'll get leaks around the nose, leaks around the mouth, and also their mouth can open up. So you give them pressure and their cheeks will blow up, their mouth will open up, and so they'll lose a lot of their pressure that way. So they've come to develop these full face masks or oral nasal masks that fit over the nose and the mouth to prevent some of that leaking through the mouth. And this is probably the most common used mask that you'll see today. It usually has kind of a silicone gel cushion around it that helps prevent leaking around the nose and around the mouth. So that's one of the things. Again, these can be uncomfortable because they sit on the bridge of the nose, and if you use a lot of pressure, sometimes you can get into problems with the skin there. This is a full face mask, and this is probably the one that I like the best just because I think it's more comfortable for the patient. It fits over their full face rather than sitting on the bridge of the nose, so this is not as uncomfortable there. You do have to have somebody who's got a jaw there, so some people don't have a very good jaw or they don't have teeth, and so they don't get good support from the mask. That's one of the things that can be a problem. The other thing that you can use is the nasal pillows, and they have some other different types of nasal pillows, but these fit right up inside the nose so that it allows the flow of air and pressure into the patient. Again, you have a problem with the air leak through the mask. One of the things that you can do is use a chin strap that maybe helps hold the chin upright. Some of the complications that you can have from non-invasive ventilation, obviously you can have air leaks because the mask moves or the patient moves, and so that can be uncomfortable. So you want to make sure that you use a mask that is comfortable for the patient. You want to use straps that are fairly tight, but you don't want it to fit so tight on the face that it's too uncomfortable for the patient. You want to try to limit the amount of pressures if you can so that they're not having air leak, but they're able to get adequate ventilation. You can get, I mentioned earlier, you can get some skin irritation along the nose or along the cheeks, so you want to, again, loosen the straps so that they're not too tight. Again, choose a mask that's appropriate for them, and sometimes you can use some artificial skin or some dressing to help provide some cushioning over that area. Some patients are claustrophobic. They don't like having the mask over their face, and so that may make it hard for you to treat them. So you may want to use a smaller mask. That's where the nasal pillows may come into effect. Sometimes you can give some mild sedation as well. Particularly in the ICU, I would use that. They may have congestion, so you may want to use antihistamines or some nasal decongestants to try to help. Use humidified air. They can get dryness as well, that I talked about, or mucus plugging because of that. And again, humidity may help with that. Also, if somebody has a pneumothorax or they can get a pneumothorax, you would want to stop the ventilation at that point in time because you don't want to create more problems with their air leak, and you may need a chest tube in that case. Some other pitfalls are you fail to recognize that they're getting worse with their ventilation, and so you put them on that, you walk away, and you don't check on them in an hour or two, and they're worse. So again, you want to follow these patients fairly closely. You can't relieve their anxiety or their claustrophobia, so you end up having to intubate them to try to help to get adequate treatment of their respiratory failure. They're not able to clear their secretions, so you've got this mask on their face. It's hard for them to cough and clear things. They may not be able to swallow real well, and so that secretions can be an issue. You have to keep that in mind. Also, if they have problems with gastric distension because of the pressure, the amount of pressures that you're having to use, they can get into problems with reflux or emesis, and they can aspirate. And so those are problems that you have to consider when you're looking at use of non-invasive ventilation as well. world peace. So there have been some articles that have come out. This is a state-of-the-art article, came out in 2001 from the American Thoracic Society, just describing the use of non-invasive ventilation. And then this is clinical practice guidelines now are starting to become available. This was in 2011 from the Canadian Medical Society, looking at use of non-invasive ventilation. So you have international recognition and use of non-invasive ventilation. So if we all use non-invasive ventilation, our patients will get better. Actually, the European Respiratory Society also has a monograph that came out, I think, in 2007, where it's several hundred pages where they talk about the use of non-invasive ventilation. So everybody, I think, around the world is recognizing that non-invasive ventilation can be a good thing to use and should be considered in this. So what are some alternatives to non-invasive ventilation? Say our patient is not tolerating non-invasive ventilation. And this is something that has come about within the last few years is super high flow oxygen is what I like to call it or whatever. So we have the high flow oxygen, 10 to 12 to 15 liters of oxygen that we can give through a high flow nasal cannula. But this is a type of treatment that allows super high flows of oxygen, up to 40, 50, 60 liters of oxygen that you can give to the patient. It requires an oxygen source, so your wall oxygen. You have a blender so that you can actually affect the FiO2 from 100% down, that it blends air with it. You need to have a humidifier because you're providing very high flow of oxygen, so that if you don't use any humidity, this is really going to dry things out very quickly. And then you have a nasal cannula that generally is a fairly larger bore nasal cannula, again, that sits up inside the nose and has a fairly occlusive seal to the nose. This may be more tolerable than a face mask for non-invasive ventilation. It does help improve respiration by decreasing the dead space of ventilation, so you get this high flow of oxygen washing out all the room air and CO2 that's in your oropharynx, your hypopharynx, in your airways, and so you're really breathing oxygen-enriched gases that are coming into the lungs. It also may give a mild increase in the airway pressures because the flow of oxygen is so high. It may be higher than your expiratory flow at some point, and so you can actually get a CPAP of about 5 or 3 to 5. I think they've suggested with the use of this device, and it can be helpful in treatment in patients that have acute hypoxemic respiratory failure. This was a study that came out last year that, again, comparing the use of this high flow oxygen therapy to non-invasive ventilation and standard therapy of ventilation. Was a randomized study looking at patients who required intubation. And actually, with the use of non-invasive ventilation, the intubation rate was higher with the use of standard therapy and non-invasive ventilation. With high flow oxygen, they were able to avoid intubation in a lower number of patients. And so that has been shown to be somewhat helpful. Also was associated with a higher level of comfort. It had a reduced amount of dyspnea and respiratory rate, and actually they had a little better survival as well. But this was not was helpful, but it may have been related to the fewer number of intubations that occurred in patients with the use of this device. So it's a new therapy that is available, that you may see us use frequently on the floors, and the respiratory therapists will say, well, what about the super high flow oxygen? It's something to consider and can be very helpful, particularly in patients who are having an oxygenation problem and not a ventilation problem, a CO2 problem. So a brief word on invasive ventilation. You need to consider that this is a standard management for patients who have respiratory failure, particularly when a patient is unable to support himself with non-invasive measures. It does require an ICU level of care, whereas the others can be managed on the floor, particularly on a step-down unit, a telemetry unit. It frequently requires sedation to help patients tolerate it because you've got a tube stuck in the back of their throat. Patients generally don't like that initially early on. It can be associated with the development of pneumonia, GI bleeding, and venothromboembolic disease. So those are some of the complications that we see with use of invasive ventilation, generally because patients stay on it longer than they do with non-invasive ventilations. And so when we start invasive ventilation, you want to try to wean the patient early and try to minimize the therapy as soon as their condition allows. So I know I hadn't talked a whole lot on invasive ventilation. I've talked more about non-invasive ventilation just because it's something to consider, it's something good. Kind of in summary, respiratory failure can either be in problems from oxygenation or ventilation. We've gone over that. So be sure to identify, is this oxygenation, is it ventilation, is it both? The goals obviously should be to try to maintain an O2 sat above 90%, and then you adjust your treatment for hypercapnia. So make sure we correct their oxygenation first, and then see if they have problems with CO2 retention or hypercapnia. Non-invasive ventilation with oxygen or positive pressure ventilation or CPAP ventilation can be useful in patients who are able to sustain themselves and cooperate with care. So you can use just a straight CPAP or positive pressure without the boost from the inspiratory pressure. In patients who are able to sustain themselves and cooperate with care, it can be particularly useful in patients who have severe COPD, have acute pulmonary edema associated with heart failure. So remember those things. High-flow nasal cannula, oxygen can be an alternative strategy to use in patients who have severe hypoxia but are generally eukapnic, so their PCO2 is less than 45. The super high flow may be a good alternative to use. And you always need to be ready to intubate the patients who fail these non-invasive strategies. Make sure that you intubate them early because delayed intubation is associated with higher morbidity, higher mortality, higher complication rates. And that's really the kind of the pearls, I guess, of treatment of non-invasive ventilation, of respiratory failure with non-invasive ventilation that I had to talk about. These are some of the references that I used to kind of put this talk together, and that's about all I have. So if I have any questions, certainly. Otherwise.
So if you have somebody with COPD, how do you pick your pressure?
So I try to use the least amount of pressures that they're comfortable with, that they're able to ventilate, that I see that they're getting an adequate tidal volume. And an adequate tidal volume for me is probably 400 to 500 cc's of tidal volume and that kind of thing. I put them on there and I see if they're comfortable with that and they're getting adequate tidal volumes through my ventilator, and give them time.
So you use the inspiratory pressure?
Use my inspiratory pressure to gauge what my tidal volume is. Yes, I'll use generally a lower EPAP or PEEP, 3 to 5, depending on how bad they are, because they may have a hard time trying to breathe against that pressure as they're exhaling. And then I'll use my inspiratory tidal volume then to try to give me a tidal volume that's, say, like I say, I'll use 400 to 500 cc's just because that's easy. The ventilator machine tells me this is a number as opposed to 6 to 8 to 10 mLs per kg, but most people I find are in that 400 to 500 range.
In particular, the COPD patients, do you make them wear it constantly?
Early on, I will, but as they improve, as they get to where they're more comfortable, their blood gases improve, their respiratory rate slows down, and they appear more comfortable, then I'll take them off of it and just put them on oxygen and see how they do. If they were severe when they came in, I may give them, particularly my more obese patients, I think, more so than my emphysematous patients. I'll use it because they tend to have more problems with obesity, hypoventilation. I'll use it maybe for a time interval, say 2 hours on it and 2 hours off of it, and try to increase the time off of it compared to being on it continuously. It just depends on how severe they were when they came in.
So if they look good, you'll give them time off to eat?
Yeah, let them be off to eat and then put them back on it. And I try to get them off as soon as they can, because none of these treatments, whether you're intubated or you have a mask sitting on your face, are comfortable. So yeah, I try to reduce it. And I think that's where the benefit of this treatment has come in patients with respiratory failure, is we can take it off of them fairly easily when they're getting better, and to see how they're doing. Whereas if you extubate somebody and they don't do well, you have to put a tube back down their throat, whereas you can put the mask on them pretty easily and get them back to where they were, where they were comfortable, and they tolerate that pretty well. Sean?
Do you have a comment on patients who improve in their exacerbating factor, maybe pneumonia or heart failure or something, but their CO2 remains high because of severe COPD, perhaps maybe it's in the 70s. So do you advocate giving them non-invasive ventilation at discharge? Is that been shown to decrease readmissions or decrease survival, or what's your thought about that?
So I have used it some, and again, it depends on the patient's tolerance. Some people just aren't going to tolerate it, and those patients, I have a long talk with them about their lung disease, the severity of their lung disease, and help them to understand that you've got really bad lung disease, and you're going to continue to have problems with breathing and with respiratory failure, and likely to come back a lot quicker because of respiratory problems. And so I tend to have more end-of-life talks with those patients. I have them with both of those patients, but I will use this as an alternative to help them to try to be able to stay out of the hospital and to try to improve things. The other thing that I do talk to them about is to try to get them to being more active, because I find that tends to help more with their hypercapnia as well. And so I try to get them involved with pulmonary rehab, or I may try to get that person into an LTAC type situation where they're in a monitored situation a little more for an extended length of time, as opposed to going directly to home.
Dr. Holladay?
Yeah.
How do you address like folks with overlap syndrome who come in who are chronically PCO2 of 70, it's 90. When they sleep at night, they have a BiPAP of like 23/18. I mean, you can't put them on like 30/20 or something. So.
Yeah, those are a lot harder. I think that what you have to try to do is just let them use their BiPAP. So those patients are using their BiPAP at nighttime only. So you just have to try to put them on it continuously and see if by continuous use you can help facilitate their ventilation during the daytime, and may help with their overall ventilation and get them back to the point where they're at their baseline. All right. Thank y'all. Hopefully this was helpful. Y'all have a good day.